Hi, I'm Scott Urquhart, Physician Assistant, Endocrinology, and Chair of the Metabolic and Endocrine Disease Summit, joined by my colleague.
Hi, I'm Lucia Novak. I am a nurse practitioner and I am faculty on the MEDS Symposium. Management of diabetes is rather comprehensive, and it takes a partnership between not only the clinician but also the patient as well. So you, me, and your A1C was meant to kind of put that in context, that this is going to be a talk that's focusing on diabetes management, but also looking at the importance of the patient as an integral partner in the management process.
I think it's a very good idea. I think when she came with that title, it would just really put a nice, the initial read of that title lets you know that it's more than just us dictating to patients, but it's about this shared decision making. I think it's really the guidance of how the whole lecture was developed. When we're looking at diabetes, our marker is simply just the A1C, with the A1C being a 2 to 3 month average blood sugar is only a small part of the story. The story really is actually two components, and that they have diabetes all day long, and there's excursions. So they have fasting plasma glucose and then postprandial glucose values. And our agents that we have in I think many clinicians, and not by any fault, but we have so many choices in medications now that it's almost kind of the bow and arrow approach, where we use one agent, and since it's a progressive disease, they immediately kind of just grab for the second agent. Whether it be right or wrong, it's not the decision I'm making here. But what I'm saying is that sometimes it's formulary coverage, and they just kind of do what's there, or whatever algorithm or consensus they're using. And we need to make sure that the sugars, the blood sugars that we're addressing, for instance, postprandial blood sugars, that we're using agents that have a better defense against those elevations in postprandial glucose. And then sometimes it's more of a fasting issue, and we use agents that are better addressing the fasting blood sugar. So we have to choose the right agent for the right dysglycemic measure that's there. Anything to that, or would you?
No, I think that is exactly what we're trying to do, is emphasize that agents have either a postprandial or a fasting effect, and knowing how to choose that agent. It's a very good question, because that's actually even more important, I think, is knowing what the patient is wanting, what their goal is, because it really is what's going to determine what you as a clinician is going to be able to do with that patient. So what is their goal as far as what kind of glucose control are they looking for? What kind of effects or side effects are they willing to put up with? No medication comes without side effects, and so we have to kind of balance those out and consider not only the side effect of the medication, but the mechanism of action of some of these agents also will interfere with certain activities of daily living, and we need to know how does that impact their ability to be adherent to the medications. In addition to that, we're looking at, well, how effective is the agent that we're looking at reducing the A1C to the appropriate goal? And probably one of the most important ones is actually cost. None of the medications that we have are free. Some of them come rather cheaply because they're generic, but a lot of the newer agents are not going to see generic for quite a few years, and they can be quite expensive, especially if they're not on formulary preferred agents. And so knowing what that burden is to the patient, again, our patients with diabetes have other health issues going on, and they require other medications, and so the co-pays can start to snowball into something that can be quite unaffordable for them. So really making them part of the team as far as really understanding where they are and what they're able to do and what they can afford and what they're willing to put up with, and helping us to kind of guide the therapy then.